the skull, right? The different regions that we have here, right? The frontal bone, parietal bone, temporal bone, occipital bone. They all the names of it, right? As you see, right? They also correlate to the regions of the skull. What does the skull do for your brain? It's essentially, again, it's a protection form that it offers. This is just same pictures of an actual cadaver, right? And we see the frontal bone, temporal bone, parietal bone, right? And the occipital bone is here. From the structures there. Once we get to the pediatric population, you will see, right? You will see these lines here, right? And in the pediatric patients, they will be called what's known as fontanels. And fontanels means that they have not completely fused, and we'll have anterior fontanel, we'll have the posterior fontanel when we get to the pediatric side of it. And there's different stages, right, or time frames when those gets fused together, right? So again, just different locations, different pictures, different views of it. Right. So you have on your cheeks, right, zygomatic bones. Maxilla is the top portion, right, of your jaw, and the mandible is the lower portion of the jaw. You're going to be very much familiar with these once we start doing intubation, right? Especially the mandible, right, which you're going to use to displace. And again, this is just some of the pictures and articulations of the bones where they connect. So I would keep these in mind. The good thing about them, they correlate, right, as I said, to the regions of your brain, the frontal, parietal, temporal, and occipital lobes of the brain, right? And they correspond to these structures. Now, this is what I want to get to. You guys have heard of a basilar skull injury, right? And when we have a basilar skull injury at the base of the skull, we want to be very mindful of a specific airway adjunct to not insert. Does anyone know what that is?
NPA.
NPA, right? So yeah, so the reason why a basilar skull injury, so you have this cribriform plate, right? So if you have a injury to the base of the skull, you may injure it. And when you insert, right, a nasopharyngeal airway, you could essentially inadvertently, right, push it back to the brain, right? So here we have the cribriform plate, which in basilar skull injury, you could essentially injure it. How would you know upon assessment? It's very hard to tell, but if the person has signs such as raccoon eyes or battle signs, right, I would be very cautious about insertion of any type of nasal airway. Also, if they have facial trauma, you may want to be careful. However, I will say this though: a lot of times, patients who have facial trauma or trauma to their face, they may have trismus or they have a lockjaw, right? So their mandible, right, the maxilla clench, and you can't open it. So at this point, the problem becomes is that I cannot put an OPA in them, right? I cannot put an OPA in them, and I need some sort of adjunct. I need some sort of airway in them. So utility of a nasopharyngeal airway may be useful, right, for those patients, but you just got to be careful to make sure, right, the patients that you are employing this for do not have basilar skull injury. Face injury in itself is not a contraindication for nasopharyngeal airway. The only true contraindication for NPA is basilar skull injury to the cribriform plate, right, where you could essentially push that nasal adjunct to the brain, right? There was only 2 case reports where this has happened, and just to remove nasopharyngeal airway insertion for all trauma patients would not be the best, plan of care, right, or standard of care. So make sure as you're assessing your patient, if you definitely believe there's a basilar skull injury, you see this battle signs, you'll see raccoon eyes, right? You see CSF leakage, right? Another sign. Then you may want to, stall off. But if you have trismus, right, and you don't see that, the other signs and symptoms, and you cannot insert an OPA, certainly nasopharyngeal airway could be one of your tools that you could employ. Right. So here I was saying, right, about the fontanelles. So in adult, right, you see essentially fusion of all the right, parietal lobe bones, parietal bone, frontal bone, temporal bone, occipital bone. But in the newborn, right, as the 3 months fetus develops, right, into a newborn, you have these, right, soft connections here. They have not fused, right, and you notice, right, here's just a bigger picture of the same thing, right? So these tissues here that I'm referring to, right? So if you look at it, right, this becomes the anterior fontanelle, right? And here it becomes the posterior fontanelle. And does anyone know, like, in terms of clinical relevancy, what is utility of it? Like, what type of data can I get from anterior fontanelle or posterior fontanelle, for example?
During
Hydration.
Hydration, right? So hydration, and the other thing I would say is intracranial pressure. So, for example, let's say if you believe a baby is having meningitis, right? Inflammation of the meninges. Those fontanelles may be bulging, right? So if you assess the head, you may see bulging of the fontanelles. However, hydration is also important, right? If the baby is, let's say, dehydrated, went through a lot of diapers, you may have sunken fontanelles, right? Sunken anterior fontanelle, sunken posterior fontanelle. The different books give you different ranges, right, in terms of closure. So one study that I saw, they said the average closure of the anterior fontanelle, which will be this fontanelle here, they estimated between 13 and 24 months. I usually like to remember anterior, right? It kind of sounds like 18, right? So rough number is 18, and the posterior fontanelle is, they say, it closes about 6 to 8 weeks, right, of birth. So why is this important? If, you know, when we gather history, right, and mom brings you a baby and says, okay, my baby is 20 months old, at this point I still may have the anterior fontanelle, right, that still has not fused, right, 20 months, but in terms of the posterior, it should have already fused, right, 6 to 8 weeks after birth. So just something to keep in mind. So anterior fontanelle, and you have posterior fontanelle. Posterior is the first one. This would be the first one to close. This would be the second one to close. The ranges is, this is 6 to 8 weeks, right? This roughly is 18 weeks, but some books you will see they'll give you a range, right, 13 to 24 weeks. So they'll give you different ranges for that, but that's just something good to keep in mind. Yes, certainly, because when you have numbers and you have one closing before the other, it's also always a good test question to put, on your exam on pediatrics, right? When does posterior fontanelle close? When does anterior fontanelle close? When is the first fontanelle to close? And what type of data can you gather from these fontanelles? Right. Any questions about this one? Right. As we make our way down from the skull, we're going to talk about the cervical, thoracic, lumbar, and sacral. Lumbar, right? The numbers here correspond to the vertebra, right? So cervical, you have 7 vertebra, and you see, right, C1, C2, C3, C4, C5, C6, C7. Thoracic vertebra is up until 12, lumbar, right, 5. We have the sacral and coccyx, right? And some of them have some important, relevant clinical features, very important for you in the field, which I want to touch on, right? So first, we're going to start with the cervical vertebra, and we see, right, we have C1 through C7. When you guys, I remember you guys doing your trauma assessment, right? You direct your partner to stabilize, inline manual stabilization. At what point in your assessment should you be putting a cervical collar?
after you check for
After you palpate.
secondary.
In your secondary, someone said secondary, right? Yes. So secondary assessment or primary assessment?
secondary.
Secondary. So truly speaking, I ask is kind of just to see what you guys will say. So truly speaking, in the field, right? If I'm in the field and the guy is lying on the ground, let's say he got hit by a car, right? I first, yes, I'm going to direct my partner to stabilize the head, right? But I will put a C-collar before I move the person onto my board, right, and move him to the ambulance before I start doing my secondary assessment. This just makes sense from the logistical standpoint. When you guys doing the assessments in the class, we have you often do it in the secondary assessment. It's just the flow of the assessment is good. But the reason why I want to touch upon this is that it's very, very important to assess the cervical spine before you place the C-collar. The reason why is that once you place the C-collar, it's one, it's in the way, right? Depending on the design of it. And two, you're less likely to be checking for any type of injury there. So what you want to do is, when I'm assessing, right, before I put a C-collar, imagine this is my arm. I want to run my fingers down the back of the neck, and I want to feel for the step off. Step off is, you know how you have steps like this, and you notice, right, for the most part, you're right up until the C7, they're kind of like in similar length to it. But what would happen if, let's say, I'm feeling, and I feel, for example, C4, right, is sticking out like this as I run my fingers. So I see that, there may be some sort of injury or fracture there. The other thing I'm looking is I'm palpating in the back of the neck. I'm looking at the patient's facial expression. Are they going to grimace, right? Are they going to make a face? Are they going to clench their teeth from the pain that, this is causing them? You want to be very careful of that, right? Because there's particular injury to the certain vertebra that, keep or innervate, I want to say, your diaphragm. Anyone know which cervical vertebra specifically involved with the diaphragm muscle?
C7.
So what you want to remember is C3, C4, C5 keep the diaphragm alive. So, and it's with the phrenic nerve, right? Phrenic nerve, C3, 4, and 5 keep the diaphragm alive, right? So if you suspect cervical spine injury, you definitely want to put a cervical collar on them, but first palpate to check for step off, check for if there's any deformities there, and see if the patient grimaces, right? If your touch is inflicting any type of pain, right? And you document that on your ACR to make sure, right, it's been assessed and been documented. Don't just put a C-collar without assessing for those things. The next thing, right, I want to talk about, right, we talked about C3, C4, C5, C1 and C2, right? C1 and C2. And let me just go back on this picture, right? You'll see this C1 is here, C2 is here. And here they have names, right? So they call C1 Atlas and they call C2 Axis. Does anyone know why all of a sudden these have these names, Atlas and Axis, and everything else is like C3, C4, and so forth?
I don't know. I think Atlas has like a mythology term type of thing.
So good. So what
is the guy to hold up the sky?
Excellent. So the guy hold up the globe, right? He's the guy, the globe, right? So if you are holding up the globe, what does that mean C1 does?
It holds up the head or the earth, or
yeah, it holds the C1 is going to hold up your skull, right? It's going to hold up your head. And what do you think Axis does? Rotate, right? We rotate side to side. So Axis, right? It's rotation, right? And Atlas holds the head. These two joints are specifically important when you guys are going to learn about intubation, right? Extending the head, putting a patient in a stiffing position, right? We extend the head in over the atlanto-occipital joint. So this joint here, right? So atlanto-occipital joint over the atlas and axis. And this should come familiar to you, right? We're extending the head, basically putting it back like that in order to gain airway control. So atlanto-occipital joint between atlas and axis, right? And here you see, right, the entire C7 here, right? Now, this is what I was referring to right here. We see the atlas. This is the guy holding up the globe. The axis is the rotation, right, around the globe or around the earth. And both of these are important factors for us in terms of, where the names come and what do they actually do, the function. So in rare instances, sometimes the name tell us about the function. So if I told you, if I wasn't sure what the C1 does and I said, well, it's atlas, and then C2 is axis, you kind of could infer, right, based on mythology, as you said, right? Well, the guy holds up the globe and rotation, right? So this is essentially what they're named after, right? As we move our way down, we get to the thoracic vertebra, right? So we have T1 all the way up to T12. And this runs essentially through your thorax, right? This is where all the major organs will be here. The other important thing that you want to be familiar is pretty much all your sympathetic stimulation will be, coming through there. As we make our way down, right, L1 through L5, the lumbar region, this and the sacral region, the sacral region and the cervical region are the two common regions that are involved in trauma, especially motor vehicle collisions, right? You have the cervical spine if you get hit, and you have the lumbar that often get affected from them, right? So L1 through L5, right? And then we have the coccyx at the base of this, right? Which is also involved in motor vehicle collisions, right? Not so much the thoracic vertebra. This is just some of the views for it, right? In front of the vertebra, right, we have the bones of the thorax. And what I want to point your attention to, right, we have the true ribs, and we have the false ribs, and we also have the floating ribs. And sometimes it's hard to keep track of all this, but what you see, right, I think the pictures kind of like paints it very well, right? So we say true ribs is up until 7, and you notice, right, if I have rib 7, it's connected to the sternum, and sternum, right, we also said was type of bone, was a flat bone. Ribs 8 through 12, they are not connected to the sternum directly, right? So that's why they call it the false ribs. And then in the back, right, you have 11 and 12, which is essentially, they are not connected to the front of the sternum. They're kind of like floating there. And remember from the respiratory lectures, I talked to you guys about bucket handle movement and pump handle movement, right? I think from this picture is kind of neat to see, right? So if I take a deep breath, right, I pull the air in, and all these ribs will essentially come out this way, right? It's like the bucket handle, as I told you about, right? These handles will essentially start to come out like that, expanding the size of the thorax, right? So that the air can come in. The front of the sternum, it works like a pump handle, right? Imagine so if I push down or push up on it, right, it will move, right? It will move the bones with it, right? So as I inhale, ribs come out like a bucket handle, and the pump handle will move the sternum along with it. So these bones assist us with our respiration and ventilation, right? When we want to take a breath, to expand our lungs, make our chest cavity bigger, which will essentially lower the pressure in the lungs, or interthoracic pressure, so the atmospheric air can come inside. We have the oxygen coming in, the fusion of gases, right? And then when we passively exhale, right, the diaphragm returns, the ribs return, right? The handles basically come down, the space in the lungs becomes smaller. You exhale, right? And the air comes out. Why? Because now inside the lungs, the air is at higher pressure than it's in the atmosphere due to reduced size of the thoracic wall. Right? So this is pretty much as I was trying to explain to you. This here would be the pump handle movement. Right, and the ribs that you saw here, right, that will be the bucket handle. The pelvis, right, and that it houses a lot of blood supply. We talked about the ischium here and the ischial tuberosity. Especially you want to palpate that when you're placing your traction splint. Do not just put it under the butt, believing that you're in the correct location. You definitely need the ischial tuberosity as your landmark for placement, right? The other thing I want to talk about is the size difference between male and female pelvis. You notice the pelvic outlet on the female is bigger, right, in the diameter, as opposed to the male. Let's see if you guys can tell me what you believe the reasoning for that is.
Isn't it for babies?
Delivery of baby.
For baby, right? I heard Helmi say baby, right? So yeah, so for the
Delivering babies, yeah.
for
Delivery.
for the delivery, right? Especially as the baby, so we call it when we look at the ultrasound, the baby's engaged. We look at the cephalic presentation at station, right? So when the baby is going to be, hopefully the head of the baby is presenting, it's not abnormal childbirth. You want that bigger outlet on the pelvis, right, to facilitate the delivery. Right. So that makes sense here, right? This is another important factor, right? If there's trauma on a female sustains trauma, even if she may not be pregnant, the bigger pelvic outlet may now have a collection of more blood in there, right? So we talked about 3 liters, right? The collection, so it can pull more blood into that area. So that's something to be cognizant of. This is just a close-up use of the same right structures, right? The pelvis. We also have the pelvic angle, right, for the male being a bit narrower, less than 90-degree angle, and the female angle is greater than 100. And certainly the pelvic outlet is wider, right, as for all the reasons we just talked about. Now, the femurs, important landmarks that you want to be familiar with, right? So here we have the greater trochanter, but here we have the femur head, and this is usually called the neck of femur, right? Here we have the shaft. The other name was diaphysis, as we talked about it earlier. Now, some things that are pertinent for you as EMTs, right? If you have we call it mid-shaft femur fracture, right? So it's a fracture in the diaphysis portion, mid-shaft, right? If there's a fracture here, right? And there's no other injuries. I want to say there's isolated mid-shaft femur fracture. What is the splint of choice?
Traction splint.
Traction splint, right? What about? I'm going to get to that a bit later, so I will keep it. We're going to talk about the. I don't want you to answer now, but we're going to talk about the splint of choice for pelvic injury. So if you have like an unstable pelvis, and then we're going to talk about if you have a fracture to the neck of femur when you arrive. Right. So these areas would be the highly vascular areas, right, where you find all the blood supply, arterial and venous supply, and that will be the trabeculae portion, right, the spongy bone locations. Right. So here, right. So we talked about traction splint as being the splint of choice if you have mid-shaft femur fracture. But now my question is, so what is the splint of choice for pelvis? So pelvis being this region here. So imagine you have a shearing injury that kind of like does this. So you have a shearing injury that fractures the pelvis like that. and now it's bleeding internally, right? The jagged edges is cutting into the vasculature, and it's a female pelvis, right? The bigger room, more area to fill up with blood, and these jagged edges cutting into the arteries, filling up with blood. You come in, you do your trauma assessment, you come to the pelvis, you see it's unstable, right? So what is the splint of choice?
Don't you use sheets?
You could use sheets. Okay, so be a little bit more like descriptive. How would you use the sheets?
Totally wrap the lenses with the sheet.
Let me ask Ian. Ian, what were you saying?
Well, I think it's a pillow wrapped around the hip and then sheets. I don't know.
Okay, but what if you only had sheets? What would you do?
You would tie it around the unaffected side.
On the affected side, and one side would be untied?
Can I answer?
Yeah, sure. Go ahead, Syed.
All right. So, I mean, what I do is I take like a pillow or a blanket, and
Yeah.
like I fold it up and I put it between the legs,
Mhm.
and I kind of tie the two legs together, starting from the hip to prevent movement.
Yeah, I see that. I see your answers, and the reason why I ask is this is often like an area where there's some confusion, right? So when you have a pelvic injury, right, you may have sometimes they call it open book fracture. They may have a shearing injury, right? So when you have a pelvic injury, here you have a lateral compressions, for example. A lot of these are caused by motor vehicle collisions, right? Here you see this this portion is right. Is broken. You may have a vertical shear, right? So the one side of it is basically fractured, and this is the open book shear, right? It's basically opened up. If you feel the pelvis is basically going to be unstable, right? You're going to push down and it's going to open up. So for these injuries, there's a couple of things you could do. So first, if you have a commercial device, here's the commercial device 1 and 2, right? So you could use that, but if in the field we don't have a commercial device, so what we want to use is we want to use a sheet, right? As Ian was saying, but you're not for pelvis, you're not going to use a pillow. What you're going to do is you basically going to wrap your sheet, right, around the greater trochanters here, bringing right these portions of the pelvis together, so that the point being is you want to close up that gap, so there is less room of the blood to pool and less chance of those jagged edges cutting into the arterial circulation, right? So this is just commercial devices you may see on YouTube. What they do is basically it functions similar as your sheet, and there's the belt. You basically cinch up the belt. It will bring that broken portion of the pelvis in. Here you have the broken portion of it, right? And what it will do is hopefully, right, it will help stabilize the pelvis. Less of it is now able to cut, right, the arterial supply, and hopefully whatever was cut, it will kind of be able to clot, right, with platelets coming to that site, as we talked about. Here is where I want the platelets. So platelets coming in here, forming that platelet plug, and this device or the sheet will allow me to basically close up the gap, make it smaller and the distance, so less blood can pool and less of the jagged edges can cut the bone. Here is an example, right, in the hospital what they use. This is from advanced trauma life support. Here they use a commercial device, right, and here you see the x-ray at the bottom, right? You see how the pelvis is basically fractured, and here you see another one. Here they used Kelly clamps, and they use basically a sheet that they tie up. You want it to be fairly snug, right, when you're doing this, because you want to basically to bring these bones in together. So for the pelvis, the sheet, right, without any pillows would be the splint of choice. Now my next question would be is, now imagine you have that elderly lady. She was taking a shower, she slipped, and she also has osteoporosis, right? Her bones is not as strong, is not as robust as she was younger, We have different stages, right? Stage 1 through stage 4 of fractures to the neck of femur. Let's say she was unfortunate one. She got the stage 4 detachment, right? So now the injury here is not actual to the pelvis. So the pelvis, we're going to say the pelvis is intact. The injury is isolated injury to the neck of femur, right? To this portion here specifically. So what would be a splint of choice in this regard? Can we do the same sheet splint, or it will change now?
We can do the sheet splint the same way.
Same way, right? Does anyone?
Yes.
This okay? So I see. So Helmi says he wants to do the same thing. He wants to do the same splint. Anyone has any alternate ideas? Would any of you guys splint it differently? This is by the way a very common injury in the nursing home that I personally encountered, or coming in. They say that my grandma was taking a shower. She filed this very common injury to see.
Yeah, well, I used to splint, a hip fracture would be like a KED. But
Okay.
instead of using it for the torso, I would just flip it around.
Yeah. So KED you could use, and there I would definitely use some pillows for some padding. So KED is good. If you did not have a KED, right, what you can do is this type of splint, right? So here, what you're gonna do is notice, right? I'm splinting lower down, so I don't want to put pressure here, right? I don't want to put pressure directly on the neck of femur, because I don't know. I don't know from my assessment, is it type 1, type 2, type 3, type 4? Is it full detachment or still attached somewhat, right? So I don't want to put my cravats up in here. I do want to connect it together with both legs, right? So the uninjured side would basically be utilized as support. Here I would want to put my blankets or pillows, whatever I can find, and this is how I would tie my cravats. This is also excellent if they have isolated neck of femur injury that you suspect. This would be also a great time you could employ your narcotic medication for pain management, right? So you may call or employ, right, fentanyl or morphine, right, which we talked about. But be cognizant, right, the distinction between pelvic injury versus a neck of femur injury. So pelvic injury, right, you want to use the sheets specifically at the higher up, right, in order to bring the pelvic bones together, right, that girdle, bring it together. But in the neck of femur, right, what I want to do is I do not want to tie up so higher up on the leg. I want to go a little bit lower down. I don't want to put any undue pressure on the neck of femur. I basically want to put these legs together, put a pillow or blankets in the middle, and tie up my cravats. So this is the distinction of the splinting methods, right, that you employ. And certainly for mid-shaft femur fracture, right?
I feel like
If you had a mid-shaft femur fracture here, the splint of choice would be a traction splint. Any questions about that? I heard someone.
So
yeah,
wait.
I actually
So
have one. I feel like, that was me. Yeah, I actually have one. I feel like the differences are subtle. So, like, if you know any surefire ways to differentiate whether someone has a femur fracture or if it's actually a hip fracture.
Are you talking about?
Like, how will we tell?
You talking about on the patient
field.
itself? Yeah. On the so good. So usually pelvis you need a high mechanism of injury. So I would say any type of motor vehicle collision, right, or maybe motorcycle collision, I would be assessing the site, right? So you had high impact, right? Neck of femur, isolated neck of femur. It's usually someone fell on the side. Usually very common in the elderly patients who have osteoporosis and they fell and they slip and they fall on their side. So the other thing you can do is when you're doing your assessment, remember we talked about assessing pelvis stability, right? So when you push down on the pelvis, and this is just a little thing I want to say, when you're doing the pelvis assessment, only one person should assess the stability of the pelvis. Not like the EMT then the paramedic unit with the EMT student who's going to be the paramedic, then one of the paramedics, then the senior paramedic, then the resident, then the junior resident, then the physician, attending physician. So no, the person who should be assessing the pelvis is probably, I would say, the more experienced person. If you feel that the pelvis is unstable, right, that should be a clear-cut sign that, pelvic injury. The moment I feel it's unstable, I don't continue like pushing it down, up and down, right? At this point, I know that there's a pelvic injury, and I'm going to go ahead and splint my pelvis. Why? Because 2 to 3 liters of blood pulled there, and the sharing injuries. I don't want to that essentially can have the patient going into hypovolemic shock, and they could die, right, from that if I don't splint it, right, if I don't correct it. Neck of femur, will they bleed significantly internally? Probably not, right, because neck of femur is not really vascular area in there, right, that they're basically going to bleed to death. It's very painful for the neck of femur, and so you want to consider, right, giving some pain medications you're assessing. So what I would say is mechanism of injury: high impact trauma, motor vehicle, motorcycle, right? I would definitely check the pelvis stability. Someone who was elderly taking a shower, and they fell in their home, most likely neck of femur, especially if they hit their side. If it took you a little bit to come, or they were like stuck until they called the EMS, you will see bruising, right? Bruising, formation, that discoloration of the skin, right? We said that hemolysis, right? The red blood cells destruction, and you may assess for that. Right? Does that answer your question?
Definitely, yeah. That's it.
Okay.